Good afternoon, ladies and gentlemen, and welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker, I have a few housekeeping items to take care of. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine, University of Hawaii. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. Please enter that into the chat box. As a reminder, evaluations are required for CME. You can find evaluations by following the link in the chat or at any time on our website and email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Nakagawa has disclosed that he has no relationships with commercial supporters that could be a conflict of interest for this presentation. It gives me great pleasure to welcome our speaker, Dr. Shunichi Nakagawa. He's an assistant professor of medicine and director of the Inpatient Palliative Care Service at Columbia University Medical Center. He graduated from Hokkaido University School of Medicine in Japan, completed a residency in general surgery in Japan, and in internal medicine at Cleveland Clinic, Ohio. He then completed a fellowship in geriatrics and hospice and palliative medicine at Mount Sinai University. He then joined Columbia University Medical Center as faculty in 2013. He specializes in symptom management in seriously ill patients and also teaches palliative medicine in New York Presbyterian Hospital. He also has many research interests, including palliative care in heart failure patients, advanced care planning, decision-making, symptom management, caregiver burden, and bereavement. It gives me great pleasure to introduce Dr. Nakagawa. This is part 2. He already presented to us in November, and this is his next presentation, which is on leading a family meeting. Welcome, Dr. Nakagawa.
Hi, thank you for introduction, and thank you for having me. I'm really honored to be able to talk to you. In I think November, I was able to give you a talk about the how to communicate, how to give bad news. We talked about spikes, we talked about the nurse, and we talked about the wish statement. And these are the sort of basic skills, basic tools in communication. But today, I'm going to talk about how you actually utilize those skills to move the conversation forward. Very common, sometimes what I see is we talk about these skills, like spikes, nurse, and restatement. And sometimes that the resident use the, name the emotion, and then, but then conversation doesn't go forward. To use the skills is not the purpose of the, serious illness conversation. We are medical professional. We need to decide the plan and what the best for this patient. So the our goal is to move the conversation forward, and then the skills we talked about is just to just how to the way to use it, not the purpose of the conversation. So I'm going to talk about 3-stage protocol in conducting and participating in a family meeting, and I'm going to discuss the importance and the methods of clarifying goals of care, and I'm going to explain various techniques to negotiate treatment options. So these are learning objectives. So let's start by case. So case is a 66 years old male. He was diagnosed with pancreas cancer like 6 months ago. He underwent the 2 lines of chemotherapy. However, he started to lose weight over the last couple of months, and then the most recent CAT scan showed liver mets. He presented with abdominal pain and jaundice. He was admitted in the hospital, and his the liver function is worse. INR is prolonged. On hospital day 3, he started to vomit blood. He had GI bleeding, and he had aspiration pneumonia. So he was transferred to the ICU. He was septic, and he was intubated and on breathing machine, and then he was started on 2 pressors. What do we need to do? Yes, we need to have a family meeting. We need to clarify goals of care. So this is the paper I published in the Mayo Clinic Proceedings, and I'm going to talk about this today. So when I, when I have a family meeting, I look at that as a 3-stage game. Maybe I shouldn't say game, but game sounds more like a fun than the family meeting. So I say this, and I call the first stage as sharing knowledge, and the second stage we call the clarifying goals of care, and the third stage I call negotiating treatment options. So let's go one by one. So first stage, sharing knowledge. What does this mean? So I emphasize the spikes. The most important thing is setting. Setting is a key. So we need to do the best job possible here. So what this means is, who do participate in the meeting? Should we bring the wife? Should we bring the son and daughter? And not only the patient side, who should join from the medical side? In the example I showed, maybe we should bring the ICU team, and also, primary oncologist should be there. So you bring those people. And you have to think what will be discussed. Are we going to talk about the prognosis? Are we going to talk about the treatment options? And also, when as a palliative care consultant, I have to think that how much authority do I have? Can I lead the conversation from the beginning, or should I let the primary oncologist talk, and then I should be just like supportive? So those things you have to think about. And ideally, you should have a pre-meeting among the medical team before the family meeting. And then you have to think about what the possible questions they might ask you. And then you have to think, you have to get a consensus. So can we say this or can we say that? And use spikes and nurse and risk statement, and then you have to start the conversation. Let's say in this example, we brought the wife and the son and daughter, so 3 people from the family side. On the medical side, ICU team, maybe attending and resident, and then you as a, I as a palliative care person, and I call the oncologist and the fellow, maybe like 5 people are there in the room. So we're sitting down, and then we are starting the conversation. So first, you need to introduce yourself, and then each one of the family member and each one of the medical team say the name and then the role of this patient, role of the the medical team, and then I think you have to make some opening statement. What we are going to discuss. I'll tell you my generic opening statement. Mine is like this. Thank you everybody for coming. And today we want to talk about a couple of things. First of all, I'd like to let you know how he's doing medically. And secondly, I'd like to share with you what the doctors are concerned about. And lastly, I'd like to hear from you about his goals and the values so that we can make a best decision for him. And we are more than happy to answer the questions you might have. So this is my generic opening statement. I think you have to create your own. And then, before giving bad news, I talked about the perception, how much they know. So we call this ask tell ask. So I say like he has been in the ICU for like 3 days, and I assume that you have been hearing lots of information from doctors. So what did they tell you? How are you explained? So this is a perception, and we let them talk. And then, I told you while you are listening, you have to gauge, how much they know, and then how is their health literacy, how educated they are. So you have to gauge these two things, and then you have to adjust yourself. Then you have to start explaining what's going on. Okay, so is it okay that I can explain what's going on? And I told you 50% rule and the 2-minute rule. So at this point, you already have your own 2-minute summary. Regardless of how complicated the situation is, you should be able to summarize that within 2 minutes. And you don't talk more than 50% of the time. This is what I said in the knowledge. And, in the patient in the ICU, when people round on the patient in the ICU, we talk about the patient with a system by system approach. What about the neurological condition? What about the cardiovascular? What about the pulmonary, the GI, the kidney function? We approach that way, but that approach is useful in the ICU round, but not in the family meeting. You can say like the creatinine is better, but there is new pleural effusion. This statement itself is very correct, exact, but in a family meeting, it doesn't convey, and then it's very confusing. What are you talking about? So the other pitfall, other thing what I see in the other residents like this. You start explaining the most recent event. He's septic. And you try to explain because of pneumonia, because of liver mets, because of like pancreas cancer. But you start by explaining what is happening right now. And this is not the right approach. Because if you start if you start with the most recent event, you give the impression to the family that, okay, so if we are able to fix the sepsis, he could get better. But that's not the case most of the time. Most of the time, I think you are able to identify the one single disease, one root problem, which is going to kill this patient. Could be heart failure, could be dementia. In this case, it's pancreas cancer. So when you make the 2-minute summary, you have to think about how long do I have to go back? Should I go back 10 years? Should I go back like 2 years? In this case, I told you that the pancreas cancer was diagnosed 6 months ago. So I go back 6 months ago. So my 2-minute summary is like this. So, he was diagnosed with pancreas cancer. And, doctor oncologist, we try to do our best to slow down the cancer progression. But unfortunately, it progressed. And because of that, he became very weak, very debilitated. And that's why he aspirated. And then he had pneumonia. And because of that, he got very, very sick. Now he's in the ICU. He's not able to breathe on his own. So that's why he's on the breathing machine. And then he cannot maintain his blood pressure. That's why he's on 2 strong medications. This is my 2-minute summary. And, this way, you are emphasizing that, this root problem, pancreas cancer, is the cause. And we are not able to fix this problem. That's why we are seeing the most recent event. And you need to make some bottom line statement. Because of this sepsis, he's very sick. We are not able to treat the cancer. And because of that, the cancer is getting worse and it's not going to improve. So this is my bottom line statement. So far, so good. But I have not still cleared the first stage. So what? So in order for me to clear the first stage, I need to be on the same page with one single information with patient or family. What is it? I just explained cancer progress. We cannot treat the cancer anymore. He's septic. He's on multiple life support. We said that. So what? We have to say the prognosis. So prognosis could be twofold. Sometimes you can say with time frame. But when I say this time frame, sometimes I hear that people using the exact number. This is 2 weeks or 2 months or 5 years or median survival of pancreas cancer is like 3.5 months. And it might be just only me, but when I hear this exact number when they talk about the prognosis, it doesn't sound real. Because no matter how precise you're trying to be, these kind of statistics doesn't apply to the patient in front of you. So I think when you talk about the prognosis, the more precise you're trying to be, the more precise you are going to be. I think it's better to be vague. So when I talk about the prognosis in the time frame, I talk with ranges of the time, like hours to days, days to weeks, weeks to months, months to years, or years to decades. Still, if you ask yourself, is this patient going to die within days? It's very difficult to say yes. It's almost impossible for you to say yes. I think question is wrong. Question should be, are you surprised if this patient died within days? And if you're not surprised, probably that's a prognosis, and then that's what you have to share. And sometimes the time frame, describing with time frame is difficult. For example, the patient with a very bad stroke, or patient after cardiac arrest and a very bad anoxic brain injury. So those patients, sometimes it's difficult to say the time frame, hours to days or days to weeks. In that case, functional status could become a prognostic statement. Even in the best case scenario, it's highly unlikely that he could breathe on his own. Probably he's going to dependent on the breathing machine, or it's less likely that he can get out of bed and walk around. Probably he's going to become bedbound, and he's not able to eat on his own. He has to be dependent on the feeding tube. So these are the prognostic statement too. Sometimes you might not know at all. You have no idea. It's still too soon for me to make any prognostic statement, and that's fine. It's still too early, and then at least we need more time, like 3 to 6 months. We have better idea, and this itself could become a prognostic statement too. Whatever it is, you should make these kind of statement. So very common situation is, if you say that, I make 2-minute summary, cancer is getting worse and we are not able to treat the cancer. And because of that, I'm afraid that his time is limited. I say like this. So when I say this, they ask me, how much time does he have left? And because I have been so emphasizing that we need to say the time frame, what I see, what residents do is, they respond right away, hours to days. How much time does he have left? Hours to days. And I flinched. I get flinched when I hear that. Because, prognosis is very crucial information. So it has to be delivered carefully. So this is how I would say, how I would respond to that question. How much time does he have left? I say like this, is it okay to share that information with you? Are you ready to hear? I cannot give you the exact number, but I can give you our best guess. And when I answer these questions, I answer with the ranges of the time, like hours to days, days to weeks, weeks to months, months to years. And in his case, it's probably in the range of hours to days. It is surprising to you. This is how I would say it. And I'm using a lot of skills here. First of all, I'm making sure that they are ready to hear that. They might ask you, but I told you that there are 3 people in the room. So maybe wife wants to hear, but the son might not. So we cannot force the information to somebody who doesn't want to hear. And because this is so crucial information, I make an invitation here. Is it okay to share that with you? And next, I emphasize uncertainty. We don't know. We don't know for sure. So I emphasize that I cannot give you the exact number, but I can give you a best guess. And this line, I'm making it vague, and then I'm preparing them. I'm going to tell you, I'm going to give you the information with one of these options: hours to days, days to weeks, weeks to months, months to years. And when I actually deliver the news, I need to give a lot of space. So I speak here super slow, very slowly. In his case, it's probably in the range of, and I take a pause. And hours to days, and take a pause, being silent. And because I know this hours to days is a crucial information, what is going to happen? They are going to become emotional. So I follow up with addressing emotion. Is it surprising to you? Is this surprising to you? I think is useful for two reasons. One is this is naming the emotion, so it is addressing their emotion. And second of all, response to this question is going to give me which direction I should go. If they say that yes, it's shocking, I'm surprised to hear that. I don't think that's too short. If they say that, that means that they are emotional. So I have to spend time and energy to address emotion. I use a nurse statement, I use wish statement. But sometimes they say, yeah, no, I'm not surprised to hear that. So that means that they are ready. They kind of thought about it, and they are ready to move on to the next step. So yeah, you look very calm. Maybe you have been thinking about this. And is it okay for us to talk about next step? So I can move the conversation forward. So this is the how I respond to the how much time does he have left. Okay, so don't give the, even if what I want to emphasize here is information I want to give is the same, hours to days, but don't just give it. You have to make sure they are ready, and emphasize uncertainty, and then expect emotion. All of these 5 lines is a set to give the prognosis statement. And because prognosis is the most crucial information, make sure that medical side on the same page. So I told you that the pre-meeting among the providers, this is a part of the setting. You need to make sure that you have to ask the primary oncologist. If they ask about the time frame, can I say hours to days? Is that okay? So if I'm able to get that agreement, that family meeting is going to become much, my life is going to become much easier. And if apparent, don't hesitate to use D word. Essentially he's dying. Patient who is a metastatic cancer, and then breathing machine and 2 pressors like maxed out. I think it's fair to say he's dying. So, I mean, you have to be careful, because once you say that, and if patient doesn't die, you lose all the credibility. So you have to be careful. But if you think it's appropriate and okay, and then all the medical providers are in agreement, I think we should say that. And once you share the prognosis, first stage is cleared, and you can go to the second stage. And but don't forget to address emotions. Prognostic statement is a very crucial information. But don't afraid. You already know the nurse statement, you know the wish statement, so you address emotions, and you can be silent. So I see somehow you are able to clear the first stage. You say some prognostic statement. You can say that. But a very common pitfall is this. You ask the question like this: do you want us to CPR when his heart stops? And this is wrong. Why is this question wrong? You could make him DNR if you are lucky, but then you get stuck. I'll tell you why. We are here and having conversation now. And sooner or later, his last moment is going to come. We just defined that his time is limited in the range of hours to days. And the DNR or CPR matters only here. You still have to take care of this patient for hours to days. So you still have to ask lots of questions. What do we do with disease-modifying therapy? What do we do about transfusion? How about lab, X-ray, antibiotics, artificial nutrition, hydration? What about CBBH? What about the breathing machine? Should he stay in the ICU or regular floor or home? So you have to keep asking these questions. Family cannot answer this question and you get stuck. That's why that question is wrong. What is happening here is you are trying to jump onto the third stage. You just share the prognosis, let's clarify the goal based on that prognosis. Even if I say, cancer progressed, we are not able to fix cancer, if I have 20 years ahead of me, of course I want everything to be done. But that's not the case. The time is getting shorter to hours per day. That's the reason why we have to clarify the goals of care. And so this is the second stage. I cannot emphasize this more. This part is missing all the time. We don't ask, these questions are not asked. And so what are the questions you should ask to explore goals? So I think this slide is the most important slide of my entire talk presentation here. I think you can forget everything else, but you should remember these questions because this is missing all the time. And the question you should ask is, with knowing that his time is getting short, what is important to him? What are you hoping for? You can ask, what are you most worried about now? How and where do you want him to spend the time he has left? You can be broader. Tell me about him. What kind of person is he? What makes his life meaningful? Or you can ask, like, what would he say if he were here and heard all the conversation? What would he say? So these are the questions you have to ask. And you need to let them talk and listen. I think, you might think these questions are not direct and it's not relevant. I disagree. These are the most crucial questions, and then these are the fastest way for you to go to where you want to go. These questions not asked all the time, and then I think it's interesting. The first stage and the third stage I'm going to talk about. You need to have a medical expertise. In order to explain the medical condition, in order to talk about the treatment options, you need a medical degree. You need expertise. But these questions, you don't need a medical training. Lay person can ask those questions. Doesn't have to be asked by doctors. Social worker or nurse. Everybody, family can ask these questions. And it could be asked before or after the family meeting. Ideally, it should be asked before the first stage. But sometimes I went to see the patient and asked these questions. What do you enjoy? What makes you happy? So before the family meeting, I asked these questions and then I utilize these information. When I asked this question to you yesterday, you said that you want to be at home and independent. So before or after, if you forget to ask these questions, I can guarantee that the conversation is not going to end well. So you have to have another conversation. So it's okay. You can come back and ask these questions. What would be important for you? What I'm most worried about? So these are could be asked before or after the family meeting. So after you let them talk and listen, if they say, we don't want him to suffer anymore, he had enough. No suffering is a golden keyword. You have to grab that. You cannot miss it. But sometimes they are not so straightforward. They can say, like, my dad is, very independent, very full of life. He likes to travel all over the world, and he hates to be, dependent. And he's a very strong person. So after you let them talk and you listen to that, you try to summarize that and you try to extrapolate from what you heard. Okay, sounds like he's a very wonderful person, strong. And, I told you that his time is getting short. It sounds like what we should do now. You want to make sure, he would not suffer anymore and keep him as comfortable as possible. And we should make sure that, he passed away with dignity. Sometimes, they say, they want to keep him alive as long as possible. So, it sounds like you want to make sure that we try to keep him alive as long as possible. And does it sound reasonable? So the point here is that you try to summarize what they say and try to extrapolate, and then you have to phrase the goals with your own words. That is the goal of the second stage. Once you're able to say something here, you clear the second stage. And then you can make an invitation. Okay, so let's discuss how we can achieve that goal. Okay, so the here now you clear the first stage, you set hours to days. And for the sake of this lecture, let's say they said clearly that we don't want him to suffer anymore. So you clear the second stage. Now you have to work on the third stage. So third stage, I call that negotiating treatment options. And here, with the long time ago, doctors were paternalistic. We know everything right, and we told the family, you should do this, you should do that. More recently, we respect patient autonomy, maybe too much, but that is very important, patient autonomy. We call this shared decision making. We have to balance somewhere. The question is, where is an appropriate balance? Let's think about that you came to the store to buy a computer. Your laptop got broken and you came to buy a new one. And one attendant came to you and he told you, I believe you have to buy this 21-inch model. This attendant is not so helpful. I mean, he doesn't listen to me and he doesn't know what I want. So this is not helpful. Some other attendant came to me saying that, model A is a 1.4 gigahertz processor, 500 gigabyte storage, and it costs like $1,000. Model B is a 2.9 gigahertz processor and 1,000 gigabyte, and then $1,500. And which one do you like? It's your decision. So this might be better than the first one, but this is also not so helpful because he can give me lots of information, very detailed, but I still don't understand what this gigahertz processor means. I still don't understand 500 gigabyte storage means. So no matter how detailed the information he gave to me, I still cannot make a decision. But actually, I think this is what we are doing a lot in the hospital, don't you think? I think more helpful attendant is like this. So what is the main purpose for the computer and how much is their budget? So I say like, what, I use this kind of presentation, I use Excel, I use PowerPoint, but I don't edit movie, I don't edit like music. And my budget is about like $1,000. That I can afford. So he says, okay, then I will recommend this model. What do you think? I think this attendant is very, very helpful. What is happening here is, we need to set the goal first. And in order to set the goal, we need to get a lot of value from the customer. So in order to establish goals, the input from the patient and family, that is the main. We cannot put our goals, our value, the doctor's value, doctor's goal, doctor's value. That doesn't matter. But once you set the goal, how to achieve that, that's where we need the medical expertise, professional expertise. This is where how to achieve that I need the help from the attendant. And I think we should do the similar thing in the hospital. So I showed this slide that we have to think about the blood transfusion, lab, X-ray, and all the medical intervention. In the normal circumstances, what are the purpose of each medical intervention? What is the purpose? Why do we do the lab, X-ray, or artificial nutrition hydration? I think the goal is to extend the survival, to buy more time. That is the goal. We don't think about it we don't talk about it, but is that what we do in acute care hospital? But once the goals of care shift from the quantity of life to quality of life, we have to think really carefully. What is the purpose of each of these medical interventions, one by one? So let's say what the mechanical ventilation can do. I think the good thing is that could buy time, could prolong survival. But how long? We just said that no matter how hard we try, the time is probably in the range of like hours to days. Downside is with the tube in the mouth that he cannot talk. It's uncomfortable. And then sooner or later, his last moment is going to come. At that time, he's going to die on the machine with connected to all the tubes. That's the downside. What about the artificial hydration? It can correct the dehydration and it could prolong survival. But again, how long? But at the same time, downside is, when patient is sick, like towards the end of life, that patient is not able to maintain the intravascular volume. It is gonna contribute to the third spacing. So it contributes to the edema, ascites, airway secretion, pleural effusion, and it might be comfortable to contribute to those. What about antibiotics? This could become tricky. I mean, you can make an argument that it could contribute to comfort by treating infections. We don't have good data to support that, but if you make that argument, I can buy that. But you also still have to think about the burden of the treatment. In order to administer the medications, if it's PO antibiotics, you have to give NG tube. If it's IV medication, you have to give IV access. If patient is making urine, I'm okay. But if patient is not making urine and the patient is already very edematous, even 100 ml or 200 ml of antibiotics fluid is going to contribute to the edema or third spacing. So if that's the case, I'm going to make strong argument that we should not continue antibiotics. But these things, could need a medical knowledge and the professional expertise. And then family cannot make a decision about this. So in this kind of situation, we generally speaking, we have like 3 pathways. If they say that, he suffered enough, just let him pass away peacefully. If they say that, what we should do is we should withdraw the life support and we should stop checking labs. We should stop finger sticks because those things are not helpful. If they say we hope for a miracle, what we should do is that we should continue the full court press. Sometimes they say, we know he's dying, but we don't want to pull the plug. We feel uncomfortable to remove the life support he's already on. It's uncomfortable. We understand that. Sometimes they say it's too overwhelming and we need time to consider. If they feel this way, what we can do is we can continue the life support, and if he can be maintained, great. But if he starts to deteriorate, we can agree on not escalate, not add more life-sustaining treatment. The point I'm trying to make here is that once you did a good job in second stage and the goals of care established, all the answers come sort of automatically. So you don't have to ask permission for each medical intervention. Like, do you want the blood transfusion, or what do you think of checking lab? You don't have to ask this because make a recommendation based on the goals of care. So based on our goal, we would not continue blood transfusion, and we should not check labs or X-rays. You make a recommendation like this and ask for feedback. How does this sound to you? Sometimes, and then we have to talk about the CPR, like DNR. And even at this stage, when they say that, when you say hours to days, and they told you that we don't want him to suffer. And then resident or trainees ask this question, to clarify the CPR, when his heart stops, do you want us to do CPR? And then I got flinched again. This is not good. We should not ask this way. they sometimes tell me, but shouldn't we present options in a neutral way? I disagree. Let's think about this, making a recommendation. I went to a Japanese restaurant yesterday, okay? It sucks. Food was bad, service was bad, and very expensive, okay? So next thing what I'm going to tell you is don't go there. You shouldn't go there. And I don't recommend there. These are the things I'm going to tell you. I don't tell you like, do you want to go there? I don't ask these yes, no questions. Really? I just want to make sure you understand. I don't say this. And if I keep asking this way, do you want to go there? Do you not want to go there? If I keep asking this way, I think you start to wonder why he keeps asking this same question. Maybe something good is there. He's hiding something. So you're gonna give the, asking yes, no questions itself is going to give them an impression that something good is there in this bad restaurant. Same here, you already did a good job in first stage. His time is short, dying, he could get worse. They already told you that we don't want him to suffer and we'll keep him comfortable. So what you should say is, we are not going to do CPR. This is the strongest statement. We are not going to do CPR. If you feel uncomfortable, you can weaken the statement like, we don't recommend CPR, or we should not do CPR. But you should not ask this way. Do you want to ask to do CPR? This yes, no question you should not ask. You might think this is subtle, but to me, this is killing me. You did a good job in first stage, second stage, and then you ask, do you want to ask to CPR? Or like, gosh, no, don't ask this way. If you want to ask this way, you think like this. You are asking that, do you want to go there to the worst Japanese restaurant? What if they are still unrealistically hopeful? Hope for a miracle. They want to try experimental treatment. First, I think you need to explore what they are hoping for. What they mean by miracle? I mean, miracle for them could mean that open his eye again and then look at them. It might be possible. But if they think that the miracle is for him to be extubated and walk out of the hospital, probably that is not going to happen. So you can give objective opinions as a healthcare professional. And respect and support their decision, even if you don't like it. Do not abandon the patient and the family. And then I have to tell you, this conversation is not one-shot deal, but a process. So I have many experiences that at the end of the conversation, they couldn't make a decision and they want to continue the full court press. But after a couple of days, after a couple of weeks, they come to us and saying that, doctor, you are right, that he looks suffering and then we don't want to prolong this. So, you don't bring your own agenda. And I think I touched upon this, do you want us to do everything? So don't say this. There is nothing more we can do. Don't say this. Nothing more we can do for cancer. That's correct. But don't say withdrawal of care, withdrawal of life support. Okay, I hear this all the time, withdrawal of care. That sounds bad. So please don't say this. And it's your decision. This is also I don't like. Like I said, based on what we discussed, this is what I recommend. Other common pitfall is like this. So you are in the first stage, and then they ask you, what are the options? And then you are tempted to respond to this question. What is happening here is they are asking the option, meaning that they want to go to the third stage. And if you start talking about, if you try to answer these questions, you are going to get stuck, I can guarantee. So the way you should respond is, in order to talk about options, we need to be on the same page about his medical condition. So let me first explain what's going on with him. So you need to redirect the conversation to the first stage. Sometimes you clear the first stage and second stage, and you are in the third stage, and then they ask you, why can't he get the chemotherapy? So this, I mean, you already explained that in the first stage. This happens. Sometimes, I thought I did a good job in first stage, second stage, but the third stage, they ask these questions. sometimes I think that maybe my explanation was not clear. So I went back to the first stage and then redo the process. But oftentimes, this is the sign of emotion. And how should we respond to this? Why can't he get the chemotherapy? This is the perfect timing for you to use "we" statement. You can say, "I wish we could," and don't say anything else. You have to acknowledge that it's so difficult for them to accept what's going on. So they can be emotional. They can ask the same question again and again. But you just said you don't have to explain all the reasons. You just say, "I wish we could," and don't say anything else, and being silent. And other common pitfall is like this. In the second stage, you ask this question: what would he want? And I want to emphasize this. Don't say "want" here. Do you know why? Why "want" is not good? Because if you ask "want," the answer to "want" is treatment options like CPR. He wants dialysis. He wants CPR. He wants chemo. Or he doesn't want chemo. So this is a third stage question, not a second stage question. So I think you are in the second stage and you are trying to explore golden values, but the question you are asking is automatically skipping the second stage and you are going to third stage. So you should not use "want." So I told you this is the most important slide. And then this is a question you have to ask. What is important? What are you hoping for? What are you worried? And how and where? And tell me about him. But don't say, "what would he want?" Okay? Don't use "want." So conclusion is, it is important to clarify prognosis when establishing goals of care. This is the first stage. We need to make it very clear. Even if you said that, pancreatic cancer so progressed and we cannot treat the cancer anymore, sometimes it's still, it's still not enough for them to understand what's going on. We have to say it clearly. Time is getting short. But because this is a crucial information, you have to ask for permission and follow up with addressing emotion. And before discussing treatment options, goals of care need to be clarified. This is the second stage. You have to ask these 5 questions. And once you establish the goals of care, make a recommendation based on that goal rather than discussing treatment options one by one. And this is my dog. Any questions?
Thank you for an excellent presentation, Dr. Nakagawa, and the really cute picture of your dog. For the audience, please type your questions into the chat box at this time. Dr. Nakagawa, I have a question while we're waiting for questions from the audience.
Sure.
What do you do when you have a family meeting where different members of the family are kind of not getting along with each other or having contradictory viewpoints?
That's a very good question. That happens all the time. I think when there is a conflict among the family, I think most of the time the family who wants to continue are going to win. It's very difficult for the family member who doesn't want to continue are going to suppress the who wants to continue. So you have to think who is a surrogate decision maker and who is a healthcare agent, I mean, if patient in a healthcare agent has a strong will to, I want to establish my dad want, my husband want. I mean, I don't care about the rest of the family said. I don't want him to suffer. If he or she says that, and I try to support that person as much as we can. Provides emotional support. But if we don't have any surrogate, healthcare proxy form, and then 3 family members have equal power, like 3 children, it's very difficult for the who wants to continue, who doesn't want to continue, suppress other people. So I think we have to just should not go to the conclusion quickly. I think it needs time. So give them time, and then continue the treatment, have another conversation in a week or 2, and then we just continue to talk.
Thank you, Dr. Nakagawa. That's very helpful. The next question is, how long do you usually spend for a family meeting?
Usually, I think half an hour to 1 hour. Sometimes 2 hours, but in my experience, if you have 1 hour, I think you can do a good job. If you cannot come to the conclusion, and then you have to spend 1 hour and a half and 2 hours, maybe it's not worthwhile. I think people get tired, and so I think after 1 hour, I try to take a pause. Maybe we gave you a lot of information. You need some time to digest what we said. And we don't have to make a decision, and then we can continue the conversation tomorrow or after the weekend or whatever. So yeah, don't try to finish, come to the conclusion.
Thank you. How do you control for other medical team members not recognizing or respecting the pauses?
Pauses. What do you mean? Like being silent, you mean?
Yeah, so if the other team members don't remain silent, so when you're intentionally pausing, but then they jump in with something.
Oh, that's a very good question. I don't know how to do. I think silence is very difficult to teach and practice, because you're right that somebody says I try to wait, and because I don't know what to say, but people feel uncomfortable, and then say something, and then silence is going to be broken. So you're right that it's very difficult, and I don't know what to do. So I emphasize to the when we teach the trainees that it's okay to be silent, don't say anything. But it's very challenging.
One of our participants suggested maybe a mini huddle for providers before the family meeting might be helpful to clarify that.
Yeah. So pre-meeting is very important. You're right, absolutely right. But it's also very difficult. How do I say? They are busy, and not all the. To me, communication is very important. But sometimes all the providers don't feel that way, and then they come late. So you cannot control everything. So I think that my challenge is that when those things happen, I try to, when I have the very difficult family meeting, I do the best job in the setting and then try to make the best environment for me. But sometimes it's not possible. So what I need to do next is I need to be able to make some recovery shot that even if the silence is not kept, that I have to control that situation somehow. It's very challenging, but that's what I'm struggling on now.
Okay, great. What do you do if the family heard a different prognosis from another provider?
Oh, that's the worst. I think that's the reason why. So when you give the prognostic statement, that you have to be really careful, because it's a double-edged sword. You're right that if they hear the 2 different things, then, and I'm a palliative care doctor, and then they hear different things from the primary oncologist, so I'm done. They don't listen to me anymore. So I have to be really careful when I say the prognostic statement. So I check in with the primary oncologist, and so if I'm able to be on the same page with oncologists about the prognosis, hours to days thing, then I think that I would say like 75% of the family meeting is done, in my opinion.
Okay. How do you recommend that medical teams with trainees communicate with each other during transitions of care? For example, when one team is going off service and another team is coming on?
Hold on a second. How, for example, when I think it's very difficult. In a teaching hospital, you have to, a team changes, rotate every week or every other week or every 4 weeks. So I think, for example, like if I want to know what happened in the family meeting, I didn't join. I have no idea about the patient, and I didn't know anything about the family meeting which happened last week. In order for me to know that I need the information about 3-stage protocol. So in the family meeting, what kind of prognostic statement was made to the patient and family? Did we say hours to days, or we didn't? That I need to hear. And second stage information, that what the family said about the goals of care. Do they want him to live as long as possible, or do they want him to be, give him more time for another week or two? So that's the information I need to know. So as long as I have information about the first stage and second stage, and then what we agreed on, like in the last family meeting on as a third stage, I have a picture and I can take over from there. So probably I would, how do I say, advise that each component of first and second and third stage is, I think, key information to talk about the goals of care.
Okay. Can you mention how you document the family meeting in the EMR? Do you have any specific format that you use, Dr. Nakagawa?
So that's, like I said, I think that's how I document that. I used to document like, the patient A said this, and then doctor A said this, and then to that, family respond to that. And then you can describe like that, medical student does describe like that. They are, they are very smart and they are very precise about this. These things are, there is no right or wrong way to document a family meeting, in my opinion. So you can do whatever you want. But like I said, if you document that way, I think I have to go through each line by line, and then sometimes it's time consuming. So as long as I have that 3 component, what we set in the family, in the first stage, what we set in the second stage, and then that, because of that, we agreed on the third stage, continue full court press or just time-limited trial for another week or 2. As long as you have that component, I think that's enough. So when I document like that.
Okay, thank you so much. I think that's the end of our questions. Thank you for a very informative series, Dr. Nakagawa, for the first one and the second. We really enjoyed it and learned a lot from you. I want to remind our audience, please complete the evaluation in order to get your credits. The link is in the chat box, and it's also in the invitation that was sent out by email.
Yeah, if you have any further questions, sorry, don't hesitate to contact me. I have email there. I have a Twitter account there.
Thank you so much, Dr. Nakagawa. Okay,
Thank you.
Thank you. Bye-bye.
Bye-bye.